Good morning, everyone. I'm Caroline Handley from the Workforce Development team at Murray PHN. I begin by acknowledging the traditional owners of the land on which we work and live. We recognise, celebrate and respect Aboriginal and Torres Strait Islander people as the first Australians. We acknowledge their unique cultural and spiritual relationships to the land and waters as we strive for healing, equality and safety in healthcare. We pay our respects to the elders, past, present and emerging, and extend that respect to all First Nations people. I'd now like to introduce our presenter today, Narelle Williamson. Narelle is an asthma and respiratory educator and senior clinical consultant at the National Asthma Council Australia. Thank you for joining us this morning, Narelle.
Thanks, Caroline. Good morning, everyone. Thank you for joining in so early. You're all bright buttons and up and early and getting our brains switched on to face the day. I hope everyone's staying safe in these COVID times. It's really a testing time for a lot of us, isn't it? So all of you take care. All right, so this webinar this morning, as you can see on the screen, is obviously asthma in spring, allergies and thunderstorms. So our learning objectives for today are going to be to describe the association between allergic rhinitis and asthma. We're going to summarise the treatment guidelines for allergic rhinitis. We will describe those people at greater risk of thunderstorm asthma and the guidelines for management. And we will summarise the importance of written asthma action plans and also first aid for asthma in this thunderstorm asthma season. So it's good timing that you have this webinar this morning that Caroline's organised for you, given that spring is tomorrow and we're very much going to be at risk in southeastern Australia for thunderstorm asthma. Just before we start, this is the Australian Asthma Handbook. The latest version was launched last year in September. It's version 2.1, and this is written by a group of respiratory experts according to evidence-based best practice asthma management, diagnosis. It's really easy to use, so jump online, type anything into the search function there, and you can find out about anything to do with asthma and COPD, but it's really useful. And then we also just like to show our National Asthma Council website. I sort of to and fro between saying we're in the office, we're out of the office, we're in the office, we're out of the office. At the moment, we're of course working from home down here in Melbourne. But if you would like any resources, any of the charts that you're about to see in the presentation, any action plans, anything at all, please feel free to jump on this website and order online, and one of us will go into the office and package things up for you and send them out. All right, so allergic rhinitis. So many of you may not know that approximately 15% of Australians have allergic rhinitis, or what is commonly known as hay fever. That's a really large statistics. It's often underdiagnosed, undertreated, and suboptimally self-treated. It's most common in those between 15 to 54 years of age, and it's an independent risk factor in identifying asthma in children and adults. Most people with allergic rhinitis are sensitised to multiple allergens, so for example, both pollens and house dust mite. So symptoms may be present throughout the entire year. It may not be just at this time of year with spring, it may be continuous throughout the year. A lot of people these days are also developing allergic rhinitis in autumn. The most common allergens are house dust mite, pollens from grasses, weeds and trees, and animal dander, and also mould spores. Both rhinitis and asthma can be triggered by the same factors, whether it's the allergic allergens or non-specific. So for instance, odours, cold air, environmental smoke or tobacco smoke. And asthma and allergic rhinitis, is sometimes referred to as United Airways disease. As we know, asthma is an inflammatory condition of the airways, particularly the lower airways. Allergic rhinitis is inflammation of the nasal passages. Therefore, it's United Airway disease because respiratory function is determined by the upper and the lower parts. 50 to 80% of those with asthma have allergic rhinitis. In fact, it's closer to 80% now of those people with asthma also having allergic rhinitis. And it's approximately 30% now of those who have been diagnosed with allergic rhinitis also have correlating asthma. So it's really important to treat both conditions. And allergic rhinitis is actually more easily recognisable after asthma has been stabilised. So the asthma is often under control, but the allergic rhinitis isn't. So as I said, it's very important to treat both of those conditions. So it's important with assessment of allergic rhinitis to assess common symptoms. They can be local symptoms such as itchy eyes, watery eyes, runny nose, sneezing, throat clearing, cough, frequent sore throats. They can also be systemic symptoms such as sleep disturbance and lethargy. The frequency of symptoms can be seasonal or perennial. Seasonal is obviously, as the name suggests, most commonly in spring, but as I said earlier, it can be common in autumn as well. Often triggered by the pollens from the trees, weeds, grasses. And then we have the perennial allergies such as the dust mite, animal dander, molds. So we would always want to conduct a physical assessment of our patients, inspect the upper airway for swollen turbinates, that transverse nasal crease, as you can see in that picture there of the little child where he's got the groove across his nose. That's from the frequent upward rubbing of the nose when they've got an itchy nose, and it results in that transverse nasal crease, always an indicator that someone suffers from allergic rhinitis. You also might find that a patient has reduced nasal airflow. They could be mouth breathers. They may have dark circles under the eyes, indicating sinus congestion, and they also may have some sinus pain. The impact of symptoms: if people have mild allergic rhinitis, there's often no effect on their day-to-day function. But if they have moderate to severe allergic rhinitis, often the impact is great on their everyday daily activities. So it's important to identify the patient's triggers, whether it's the grasses, the animal dander, the chemicals, the irritants or the fumes, particularly in people's workplaces, and conduct this physical assessment, take history of relevant coexistent conditions such as asthma and eczema. Asthma, eczema and hay fever all very, very closely linked. So it is very common that if one person has suffered from one in the past, perhaps a child may have had eczema as a baby or as a toddler, it's very likely that they'll develop asthma. So that website there is the Asthma Handbook website. Under allergies or allergic rhinitis, adults and adolescents, you can find out more about what I've just told you. So looking at diagnostic investigations, these can be required for some of our patients, but more so in the moderate to severe category. And skin prick testing is the gold standard of diagnostic investigations. It's conducted usually these days in an allergy clinic or with an allergy specialist. We use commercially available allergens, place a drop on the arm or sometimes on the back in children because they generally don't tolerate having the allergens on the arms, and then we prick the skin underneath the allergen. We wait for around 15 minutes and we then look at the reaction. As you can see by the picture of the arm there on the right hand side, that poor patient's had a positive reaction to 4 or 5 allergens there. You can see by the wheel size. And antihistamines should always be avoided. So instruct your patient to avoid antihistamines for 3 to 4 days before they have allergy testing. IgE or RAST blood tests can be performed, but they need to be specific for individual specific allergens. It's generally not very useful just to do a RAST test, including the 50 or 100 different allergens. They need to be specific. Tests that aren't so useful, as you can see there, are food allergy testing, because generally food allergies don't cause allergic rhinitis. FBE and total IgE is pretty much of no use at all. And then there's unproven testing methods such as kinesiology, reflexology, and hair analysis. So the all-important treatment, it's really important, I think, for us to encourage our patients to speak to us as health professionals, their GP, their respiratory educator, their practice nurse, their allergist. They shouldn't rely just on over-the-counter remedies, because there are quite a lot of over-the-counter remedies and there's more and more coming on the market now. But similarly to asthma, it's very easy to walk into the pharmacy, grab a remedy over the counter. They're cheap, but really it's not going to be useful long term. So there's the first one that is the most effective in treating allergic rhinitis is those intranasal corticosteroids, or INCS sprays. Now these reduce the inflammation in the lining of the nasal passages, like the corticosteroids do in asthma, where they reduce the inflammation in the smaller airways. The intranasal corticosteroid sprays reduce that inflammation in the nasal passages. They reduce swelling of the nasal passages and also reduce the amount of mucus that is produced. Some of the sprays are available without prescription, but the stronger ones are on prescription. I'm very pleased to say, though, that Nasonex and Rhinocort, they used to be very expensive and they used to be on script. They used to be about $56, $60. Now you can actually get them over the counter, which is handy, but there are another few that I'll show you in our chart shortly that are only available on prescription. So these INCS sprays need to be taken for a long time. Again, like our preventer medications with asthma, they take a couple of weeks to work. Often patients start to take a Nasonex, a Rhinocort, for example. They don't feel immediate effects, so they tend to push them to the side and say, this isn't working. That's not the way the INCS sprays work. You need to take them for at least 2 weeks before your usual symptoms start to occur. If traditionally you're a hay fever sufferer and you know as soon as the 1st of September hits, you're going to be affected by the pollens, you need to be taking the sprays at least 2 weeks beforehand. Next up are the antihistamine nasal sprays, and these are available over the counter. These are like our reliever sprays for asthma. They provide quick relief, relief of those symptoms such as the sneezing, the itchy and watery eyes, and they usually work within 15 minutes. So patients tend to like these because they work quickly. But they're not as effective as the INCS sprays in controlling severe nasal congestion and the drip. They don't need to be used regularly to be effective, but they can be used as symptoms arise. And they can control symptoms for up to 24 hours. But as I've clearly suggested, the more preventer medications, the sprays, are a much better idea. We can have combination nasal sprays, which are a combination of the corticosteroid and the antihistamine. These are scripted in Australia. So there's a new one that's just come out called Ryaltris. That's the new spray. There's also Demista. And these sprays give the advantages of both the inhaled corticosteroid spray and the antihistamine. We also have the oral antihistamines, which are often pretty rapid acting. They're non-drowsy these days, which is really good. They're effective in controlling, again, the itching and the sneezing, but they're less effective for clearing that blocked nose that a lot of patients experience. And it's important to note that if the response to an intranasal corticosteroid alone is inadequate, despite regular daily use and correct spray technique, you can add an intranasal antihistamine and continue the intranasal corticosteroids. So again, a bit like your reliever and your preventer for asthma, if the INCS spray isn't working by itself, add in the antihistamine, and in combination they should work well. And it's not mentioned here, but I always like to mention decongestant nasal sprays and tablets that we use to unblock the nose. They shouldn't be used for more than 3 to 4 days, but they can be useful in some instances. They can generally have a rebound effect after 3 or 4 days, and they can cause the nasal passages to become inflamed. So not a good idea to use them long term or even for a week. It's not ideal, but they can be useful for some patients. Then we have the saline sinus rinses, which aren't overly pleasant, as some of you may know, but they can be very effective. They help to flush away the allergens and the irritants in the nasal passages and sinuses, and again can be good for loosening and thinning mucus. And for particular patients, they can be good if they can tolerate the awful feeling of having the saline pushed up their nasal passages. Allergen avoidance is obviously advised once the allergen or allergens have been confirmed. immunotherapy or desensitization can be suggested. It's preferred for some patients rather than the medications and sprays, but it involves a very rigorous and long-term treatment, probably 3 to 5 years to produce an ongoing benefit. Some people are happy to do that and commit to the 3 to 5 year long-term commitment. It definitely produces an ongoing benefit. I know when I was in a general practice, there weren't many patients that came back, years down the track to find that the desensitization hadn't worked. A couple of patients did, and they were willing to go through it again. But yeah, it does require a commitment. Our patients need to be referred on to an allergy specialist in order for immunotherapy because they actually order the immunotherapy. As you're probably aware, it can be in either sublingual or subcutaneous form, and obviously can modify allergic immune responses. With allergic rhinitis treatment, we avoid oral corticosteroids, and an allergy treatment plan is available at www.allergy.org.au, and I'll show you a couple of charts shortly. The NAC also have how-to videos. So on the NAC website, if you were to type in how-to videos, you will find myself and a few other of our asthma educators going through nearly all of the range of both allergic rhinitis treatments and asthma reliever and preventer medication regimes of how to use your device. Technique is so important, not only with asthma medications, but with allergic rhinitis sprays as well. So here are the couple of the treatment plans now. So they're both for allergic rhinitis, and they're available on the Australian Asthma Handbook website and also on the ASCIA website, which I just mentioned before, www.allergy.org.au. So if we just briefly run through them now, the one on the left is on the Australian Asthma Handbook website. So depending again on whether our patient is suffering from persistent or moderate to severe intermittent allergic rhinitis, or mild intermittent on the right-hand side, there's obviously a flow chart. So as I said, if you've got persistent or moderate to severe intermittent allergic rhinitis, our first step would be to try them on an intranasal corticosteroid, plus or minus that antihistamine, depending on whether the corticosteroid spray is working by itself. After that, we would consider short-term addition of an oral antihistamine and possibly the decongestant only for those 3 to 5 days. After 3 to 4 weeks, we would get our patients back into our clinics and review them. If they're controlled, you would definitely continue on the corticosteroid spray long-term, plus or minus again the antihistamine. If they're uncontrolled, we would always review their diagnosis, check a patient's adherence to the medication. Are they using it? Are they just saying that they're using it once a day? Perhaps they're only using it a couple of times a week. Check that device technique. And then we would also consider allergy testing and referring them on to an allergist. We could then add on an intranasal antihistamine, again to the corticosteroid spray, and again determine are they controlled or uncontrolled. On the other hand, if a patient isn't terribly affected by their allergic rhinitis, they only have mild to intermittent symptoms, they might benefit from just the antihistamine tablet or montelukast. I'd just like to add in here though that montelukast isn't on the PBS for allergic rhinitis. It is PBS listed for asthma, but not for allergic rhinitis. However, it is available at pharmacies. There's a pack of 28 tablets for about $12, so they're not too expensive anyway, despite not being on PBS. Then again, we would review our patients after about 2 weeks and go on, depending on whether they're controlled or uncontrolled, and reassess regularly. The ASCIA allergic rhinitis treatment plan on the right-hand side, similar to our asthma action plans. It talks about the medications and how much to use each day, whether it's a combined intranasal corticosteroid or antihistamine spray, or just one or the other as single sprays. Goes through how to use the sprays, which is always handy, and when to possibly pop in a non-sedating antihistamine tablet or an antihistamine spray try out some nasal sprays and so on and so forth. So as I said, you can find those on the Australian Asthma Handbook website and the ASCIA website. This is our new National Asthma Council Allergic Rhinitis Treatment Plan. It was just released in June. This new chart is very handy because down on the left-hand side, you'll see the little QR code for the how-to videos that I was talking about before. So videos that we've developed over the last few years on how to use the nasal sprays and asthma medications and clinical recommendations. So that's really handy to have that on those charts. These charts come in A4 size and also A3. So if you wanted to order any of those, please contact us at the National Asthma Council. So as you can see, we've got our corticosteroid sprays there, Flixenase, Avamis, Omnaris, Becanase, Rhinocort, Nasonex, and then the FES down the bottom. Then we have our antihistamine corticosteroids. These are both on script. So Ryaltris is the new one I was talking about, and Demista. And then we have, again, the saline washes. We have the antihistamines such as Azep and Levostin. We have the anticholinergic Atrovent nasal fort spray, which we don't generally find many people are on. They're generally referred to allergy specialists and they will prescribe those ones. And then we have our plain decongestants down the bottom for very short-term use. So as I said, if we haven't seen a response to treatment trials with our patients, we may need to refer them on if there's been no response in 3 to 4 weeks generally. We'd refer them if symptoms are persisting, if they become severe, or if a patient's unresponsive to the treatment that we've recommended for them. We would also refer them on to specialists if they have poor asthma control despite regular preventer medications, or if there's other allergic disease present such as severe eczema. If there's a food or occupational allergy suspected, we would also refer on. Symptoms can be worse, particularly for spray painters, for instance. We would always refer them on if they're having a lot of trouble in the workplace. And referral may in fact be to an ENT specialist rather than an allergy specialist for constant symptoms and complications such as they might have a nasal polyp that's unresponsive to initial INCS therapy. They may have ear problems. They may have persistent purulent discharge from their ears or from their nose, sinus disease, anosmia, which is the loss of ability to smell. So we would always refer on if any of those symptoms were evident. And as I've talked about, if immunotherapy is contemplated, we would discuss with them subcutaneous or sublingual availability of immunotherapy, because that's the only treatment that can alter the allergic response. All right, well, we'll have a little break. I'll have a sip of my water. Caroline, are there any questions that have come through? Or if no one's typed anything in yet, please feel free to do so, and Caroline will ask me.
Thanks, Narelle. We haven't received anything as yet. We might wait a few seconds. Okay, nothing at the moment. Thank you.
Thanks, Caroline. Feel free to, if anything pops into your head, just type it into the chat box and we can look at it at the end. Now we're going to move on to thunderstorm asthma. And here are a couple of definitions of thunderstorm asthma. And we're a little bit biased, of course, at the NAC, so we like to go for the second description there. So thunderstorm asthma, an unusual cluster of allergic asthma flare-ups, including severe acute asthma, associated with some types of thunderstorms in spring or early summer. And we'll delve into this a little bit deeper, but I do want to highlight that it's just some types of thunderstorms. I don't want people to be afraid out there that with every thunderstorm that's going to eventuate, if you hear on the news there's going to be thunderstorms tomorrow, I don't want everyone to panic. So the history of thunderstorms is shown in this slide here. And this is particularly in Melbourne, which I know doesn't always relate to everyone in our audience on these webinars. But as I'll say in a moment, it's not just been Melbourne that has experienced these thunderstorm asthma events. But you may all remember the November 2016 event that was the largest and most devastating thunderstorm asthma event ever recorded worldwide. It was very tragic down here in Melbourne. Severe thunderstorm activity had occurred throughout a lot of November. But on November 21, there'd been thunderstorms all day, and it led to thousands of people, all of a sudden suffering from exacerbations of asthma. People were finding it hard to breathe. Emergency departments, ambulances, GPs, pharmacies. There were so many people coming into all of those different places and finding it very hard to breathe. Emergency departments were overwhelmed. All health professionals were overwhelmed, actually. But there were so many people needing attention all at one time. And the majority of those affected were younger people. The median age was 32, so quite scary. And note that all of these events in this slide in the history of Melbourne have all been in November, right back to 1984, right through to 2016, all in November. But note the time of the events. So particularly the one that's in the middle of the night, 2011, there was an event in the middle of the night, around 3:30 in the morning. There were only 30 people who presented to the emergency department. In the November 21, 22, or 21st, 22nd of 2016, the onset was at around 6 o'clock in the evening. So because there were many more people out and about, of course, or awake at 6 o'clock in the evening, there were over 3,500 admissions to emergency departments. So clearly, at that time of day, compared to 2011, where people were mainly asleep, there were people out and about on the 21st of November 2016, over 3,500 admissions to ED, 35 people were admitted to ICU, and tragically there were 10 deaths. And as I said, Melbourne isn't the only place that's recorded thunderstorm asthma events. There was a significant thunderstorm event in Tamworth in 1990, in Wagga in 97, in Newcastle in 98, in Canberra 2014, and in fact I did an interview with Canberra News last week, and the ACT is very prone to allergic rhinitis and to thunderstorm asthma. In fact, 1 in 3 people have allergic rhinitis in the ACT. So it's not surprising that Canberra have had a relatively extensive thunderstorm asthma event, and probably lucky that they haven't had more, really, given their high incidence of allergic rhinitis. Several incidents have also been recorded internationally. So this is some data from DHHS about that 2016 November thunderstorm event here in Melbourne. So in the 30 hours after 6 o'clock at night, there were 3,365 excess respiratory related cases presenting to Melbourne Metro emergency departments. That's a 672% increase above the 3-year average, and 476 excess asthma related admissions to hospitals in Melbourne, to public hospitals, which is a 992 increase on the expected. About 2/3 of the people, interestingly, who presented to emergency departments didn't know that they had asthma or allergic rhinitis. They felt that they'd had a few allergic rhinitis or asthma symptoms in the past. They might have reported that they'd had, a bit of trouble playing sport in the past, or as a child they were taken to hospital, but hadn't thought about it really until this event. And a lot of people were subsequently diagnosed with asthma or allergic rhinitis. So what is it about springtime conditions that bring on these thunderstorm asthma events? Well, for a thunderstorm event to be significant, it has to be a high pollen day. And the reason that November is the common month for these thunderstorm asthma events to occur is that there has been a high amount of rainfall. Generally, in the past decade, our seasons have become warmer. So there's warmer temperatures, high amounts of rainfall, and therefore the grasses grow, which means that the pollens grow. So for springtime conditions, there's high concentrations of these pollens, and it's mainly ryegrass, but it could also be alternaria or fungi and or dust. Perennial ryegrass has been implicated in most Australian thunderstorm epidemics. And you can see the map there of the Victorian rainfall there down the bottom, where the dark purple indicates the highest rainfall recorded, and the lighter shade of purple is an above average rainfall. So you can see in 2016, due to that higher amount of rainfall, the growth of the grasses was prolific, therefore a lot more pollen, and then the thunderstorm came. I might also add that we're due for and have had a very wet season of winter, a lot of rain. Temperatures are above average, so we're keeping our fingers crossed that there's not too many thunderstorm events this year, but it's likely, because as each year goes by, there's more and more rainfall and, as I say, those high temperatures. So normally large pollen particles can be filtered in the nose, and they're around 10 micrograms in size. When thunderstorm moisture breaks down pollen particles, it breaks them down to less than 2.5 micrograms. So these particles aren't filtered in the nose. They go through the nose and, of course, through the mouth, and they get right down to our smaller airways. And this is why the asthma occurs. And it's not only asthmatics that are at risk, it's those with allergic rhinitis. So the exposure of people who are sensitive to pollens, could be dust, are going to be exposed and at risk. Here's a slide that represents one hypothesis for the mechanism of thunderstorm asthma. So let's imagine we've had warmer than usual temperatures, we've had higher than average rainfall, we've got a lot of flowery grasses and a lot of pollen. The whole pollen grains get swept up into the cloud as the storm matures. There's an updraft. The moisture in the cloud fragments the pollen into those smaller pieces of about 2.5 or less than 2.5 micrograms in size. Then there's the downdraft that occurs with the thunderstorm, and the dry cold outflows carry the pollen fragments to ground level, where people breathe them into their lungs. So that's a really good slide just to demonstrate. So the strong wind gusts that precede a thunderstorm provide a very efficient mechanism for exposing large numbers of people to lots of pollen allergen suddenly and in large volumes of people, obviously. These gusts may travel over large areas before diminishing. These people in large groups are affected by asthma symptoms at similar times during these sorts of events, and that's why it's called epidemic thunderstorm asthma. There's been some new research out of the UK in April this year that suggests there may be other impacts such as lightning. I haven't seen too much more research apart from this one trial, but I think it's safe to say that this hypothesis is one that we can definitely stick with. And if anything is updated with regards to different mechanisms for thunderstorm asthma, it will definitely be on our website, so keep an eye out. This little video, I'll just grab my mouse here, is a visual representation of pollen rupturing. I can get it to go. Sorry, guys. Let me see. It's not going to play for me today. It played for me yesterday when Caroline and I were having a practice. No. Oh, sorry about that. I'll go back here. This is supposed to play and show you that those larger circles, which look a little bit like balloons, they're the 10 microgram or normal size pollen particles, and it just shows them rupturing into the tinier little particles you can see on the right hand side down the bottom there. So it just indicates that the moisture in the thunderstorm comes down, hits the pollen particles, they rupture into the smaller sizes, and that's what's inhaled. So I'm sorry that's not going to play for us at the moment. So who's at increased risk? Well, there's people in many different categories. First off, we'll start with people with a sensitisation to ryegrass pollen. They are at a very huge risk of thunderstorm asthma. People with seasonal allergic rhinitis related to grass pollen who have asthma or who have never had asthma, they are also at risk. Of course, patients or people with asthma who have had asthma for a short time or a long time, they are also at risk of thunderstorm asthma, obviously, but especially if they're poorly controlled or they're not taking their preventer. Those people that have ever had asthma, for example, we might have encountered a patient who had childhood asthma and they feel that they've grown out of it, and they may very well have grown out of it, or they've got it under control, but more so that they've had childhood asthma, they can still have those twitchy and sensitive airways. And when those smaller pollen particles hit those lower airways, the airways are reignited into recognizing that there's a trigger and sensitivity, and therefore they will all of a sudden have an asthma exacerbation. They may not have had an exacerbation for years or decades, and then all of a sudden these smaller pollen particles trigger their old asthma, if you like, to get triggered. And this risk increases even more in patients with both asthma and allergic rhinitis. And as I said, people with underdiagnosed asthma, or undiagnosed asthma, I should say. And people exposed to open air before and during a thunderstorm in pollen season, they're at a high risk category for developing thunderstorm asthma. And of course, those people living in an area prone to high pollen counts, historically southeastern Australia, and I'm not sure precisely where you've all joined in from today for the webinar, but I assume some are from Albury, some might be from Bendigo, all of that area in your Murray PHN, we are all at risk. So general advice for those at risk. So one of the big risks about thunderstorm asthma is that for many people, it's completely unexpected. So people aren't prepared, they may not have awareness of thunderstorm asthma, they may not have their reliever medication handy, and they certainly, unfortunately, may not have an asthma action plan. So the general advice, not medical advice, but this is just general advice for all of those categories of people who are at risk, is to avoid outdoor exposure when pollen count is high and a thunderstorm is predicted. And there's a few ways that we can identify when there's going to be a high pollen count or thunderstorms are predicted. One is by downloading the AusPollen app. So the AusPollen app is available in every state and territory. Here in Victoria, we have the Melbourne pollen count. The AusPollen app, you can actually scroll down and select your closest pollen station. There's about 20 pollen stations in Victoria, for example. So you just scroll down and select the closest station to yourself. Then there's the Aerator app, www.aerator.org.au. It is a very useful one. And then we've also got in Victoria the Vic Emergency website app. There's also the New South Wales State Emergency Service app. So those three sites or apps are extremely useful, very easy to follow, very easy to download. I check the AusPollen Melbourne pollen count app every morning. Fortunately, at the moment, pollen is low, but I'm expecting it to get very high. Of course, the other way to keep in touch with what's happening in our weather is the weather forecast each night on the news. And usually at this time of year, they also report on the pollen count. So that's another way to keep track of what's going to be happening in the days to come. If we're in our house or car, other general advice is to close windows, turn off air conditioning, or use recirculated air on high pollen days or thunderstorm event days. If there's any signs of asthma, follow your written asthma action plan, or if there's no personalised action plan, then follow the asthma first aid steps, which we'll be going through shortly. If someone is having an asthma attack or asthma symptoms are increasing, call 000 and tell them on the line that you're having an asthma attack. Now looking at medical management for those with asthma and allergic rhinitis, it's really important to be proactive in spring. Arrange a review appointment with the GP. A lot of people are reluctant to go into clinics at the moment because they feel that unwell patients potentially with COVID are in GP clinics, so they don't tend to want to go in. But advise them that there's telehealth, and telehealth is a perfect way for a review appointment of allergic rhinitis and asthma plans. Discuss the increased asthma risk, of course, and assess for allergic rhinitis. The patient needs to know and understand how to manage their triggers, and unless they're being reviewed by their doctor and reminded, they're not going to be managing their symptoms too well, and they'll be at higher risk for developing thunderstorm asthma. They need to take their prescribed medications, they need to understand their reliever therapy, they need to have correct device technique. I'm not sure if the clinics that you work in, whether the doctors have not face-to-face, not telehealth, but on video. in conference video calls. A couple of the clinics that I work at in respiratory clinics, they have video calls for patients, and that's a perfect way to check device technique. We need to manage and regularly review patients with asthma following the current guidelines from the Australian Asthma Handbook. The latest guidelines indicate that very few people should be on SABA alone, so that's short-acting beta agonist or reliever medication. So very, very few patients now should be just on reliever medication. They should be on preventer therapy, and that is usually inhaled corticosteroids for most people. There's a couple of medications, Seretide and Symbicort. They're what we call combination medications. They have a preventer and a reliever within the medication. And as I said, the new guidelines suggest that even people with mild asthma should be on a combination medication now, not just have reliever. Having said that though, all patients who are at risk of thunderstorm asthma or who have asthma and or allergic rhinitis should always carry their reliever therapy. It can be Ventolin, it can be Bricanol, and we would always want to check device technique, as I said, and their adherence to their medications. In management of our patients, we'd want to encourage proactive treatment for allergic rhinitis. So intranasal corticosteroids should be, we say 2 to 6, so we've written here 4, we've taken the average, but 2 to 6 weeks before pollen season, they should be starting their intranasal corticosteroids. Pollen season here in Victoria and also in New South Wales commences on the 1st of September. So that's tomorrow. So anyone with asthma or allergic rhinitis or both, or those people who have known from previous thunderstorm asthma events that they're at risk, they should already be taking their intranasal corticosteroids and or their intranasal sprays for their asthma. And as I've said again, ensure the asthma and rhinitis asthma action plans are up to date and understood. So those people with allergic rhinitis but no asthma, what should they do for management? So these people are at risk if they live in a region or travel to high pollen areas, including those who have never had asthma before. They need to manage their allergic rhinitis as per the guidelines. They need to identify their allergic triggers. It could be grass pollen, it could be dust, and they need to be treated with the intranasal corticosteroids beginning 4 weeks before and throughout pollen season. If they live in or are travelling to high pollen areas, we need to educate them on the risks of thunderstorm asthma and explain how to recognise asthma symptoms and what to do. They need to know how to get a reliever. As I said earlier, they are available over the counter. Ventolin is only about $9 now over the counter, but they also need to know how to use it, and that's where our pharmacists particularly come in. If our GPs have not had time to show patients device technique, we rely on our pharmacists and our nurses and respiratory educators. We also would want to provide first aid information. They really need to know how to recognise asthma symptoms, and it's really tricky too, I think, in these COVID days, because a lot of asthma symptoms can also be COVID symptoms: shortness of breath, wheezing, runny nose from allergic rhinitis. They can also be COVID symptoms. So it's really important that if patients have experienced allergic rhinitis in the past and they know what their typical symptoms look like, if their symptoms this year are a little bit different, we very much push for them to go and get tested for COVID, because it may not be allergic rhinitis this year, it may very well be COVID. For those people with no seasonal allergic rhinitis and no asthma, we need to reassure these people that their risk is generally low. But we do need to raise awareness of asthma first aid for all people. Written asthma action plans, hopefully these are all very familiar to you. Written asthma action plans improve health outcomes by improving asthma control and by monitoring symptoms. Severe or life-threatening asthma attacks are likely to occur more so in people with inadequate medical supervision. And if they can't get medical supervision, or they don't have access to GPs, or they're not willing to have an appointment with a GP, the written asthma action plan definitely is what they need. They improve outcomes by improving asthma control, as I've mentioned, and they enable patients or their carers to recognise worsening asthma symptoms. This action plan that you can see here on this slide is the National Asthma Council Action Plan. The one that's folded up there into a tiny little wallet size is very handy. It folds out into A4 size. And as I said, it helps patients or their carers, or both, to recognise increased symptoms, whether it be wheeze, cough, breathlessness, waking in their sleep in the middle of the night with any of those symptoms. They give advice for adjusting medication, advice for when to see the doctor, and also when to call an ambulance. Hopefully no one ever gets to that point. But as you can see there, I know it's very small, but we have a category for when the patient is well, when they're not well, when their symptoms are increasing, and when their symptoms are severely exacerbated. It goes through how to increase the medications, what extra steps to take, and as I say, hopefully they don't get to the point of needing an ambulance, but it's all there written down for them, very easy to follow, because if any of you have ever had an exacerbation of asthma, or you're a family member of someone who has had an exacerbation of asthma, it is extremely scary. Sometimes we just can't quite remember how to deal with an asthma attack. So the written asthma action plans are very, very important. Of course, action plans need to be personalised. They must be in a language that the patient understands. That's pretty obvious. But you can look up a few different types of asthma plans on the NAC website or under the Australian Asthma Handbook website. They come in a variety of forms. The National Asthma Council obviously have ours. Asthma Australia have those for children. Often schools and kinders will only accept the Asthma Australia Victorian schools or New South Wales schools action plans. The Royal Children's Hospital, as I said, and our practice software such as Medical Director and Best Practice, they will have their own form of action plan as well. This is the pharmacy or community first aid protocol, and these charts are actually being updated as we speak with the National Asthma Council, but it's the children's first aid for asthma and then the first aid for asthma with adults. They give the same instructions, but as I say, they're being reformulated to have not quite as much writing on them, but the general consensus is that community first aid protocol is what you use if someone doesn't have their personalised written asthma action plan. You follow the first aid guides. And this is what it is. It's the 4x4x4. Hopefully you've all heard of it. So firstly, we give 4 separate puffs of SABA, i.e. Ventolin, via a spacer. The patient suffering from the attack takes 4 breaths per puff. You then wait 4 minutes, and if symptoms persist, repeat those steps. So 4 separate puffs of Ventolin, 1 at a time. The person takes 4 breaths through the spacer per individual puff. Once those 4 puffs are being given, you wait 4 minutes, and if the symptoms persist, repeat those steps. If there's no improvement, continue steps 1 and 3 continually until an ambulance or other medical help arrives. It'll usually be an ambulance. So the 4x4x4, very easy to follow. This protocol is in all sporting clubs around Australia. It's in all schools, many community halls, lots of different places. So that's the way to go. This chart is available on our site. As I said, we will be updating it within probably the next month. We've had a few staff changes, but they're being updated and very important to follow. They're available in an A4 size, and they're also available in A3 if you wanted them for your clinic settings. So how do we prepare for springtime thunderstorm asthma season? If you're in a clinic situation or in any healthcare setting, but particularly at clinics, prepare early. Proactively review those patients with asthma, especially those with a history of springtime asthma, allergies, previous thunderstorm asthma. Be aware of high pollen days and the thunderstorm weather forecasts. Ensure you have a plentiful supply of bronchodilators such as Ventolin or Bricanol, whatever you prefer to keep in your setting. Ensure they're in date, and as I said, that your supply is adequate. Have also a good supply of spaces. That was one of the issues in Melbourne back in 2016 with the thunderstorm event. Hospitals ran out of Ventolin and they ran out of spaces. It's important for your clinic to have a policy for patients presenting with an asthma flare-up or an attack for all staff, including your receptionists, your practice nurses and your general practitioners. They should all know their responsibilities in dealing with a patient who will present with an asthma flare-up. So train all those staff in asthma first aid and have those charts that we've just shown, have them on display, and use telehealth during COVID for reviews. The Asthma Australia coach program, 1-800-ASTHMA, as you can see on the bottom of your screen there. That's a free health service delivered over the phone by trained Asthma Australia coaches. And that program helps to guide people with asthma, helps to care for people with asthma and improve their general health and well-being. So the coach program is a great program. It's definitely worth looking into or advising your patients about it. In pharmacies, what can we do? Well, we can ensure, again, adequate supply of asthma medications, maintain an adequate supply of spaces also, have a pharmacy policy for patients presenting with an asthma flare-up or an attack, and they can also get the flowcharts available from the NAC. All staff, including pharmacy assistants or dispensing technicians and pharmacists, they all need to know their responsibilities and prioritise these patients if they present. Train all staff in asthma first aid, have our charts on display, know which GP clinics are open and which clinics are able to assist if appropriate. And it's also advisable for pharmacists to know where the local COVID testing clinic is as well. For patients requesting hay fever medications, again, talking about patients that will come in and just want to buy those over-the-counter inexpensive remedies, the pharmacist should really recommend a GP review, particularly if asthma symptoms are identified or they feel that symptoms might be a bit worse than what the patient's alluding to. We really rely on our pharmacists to work together with clinic staff, hospital staff, and then hopefully we'll find that there's less patients presenting to emergency departments. So just a few thoughts to consider for you. Does your clinic or your healthcare setting have an emergency asthma plan policy? And who has responsibility for the different aspects of care in that plan? Is there a consistent approach to emergency asthma management? Does everyone in the practice know where a reliever is kept and a spacer, hopefully? And you can refer to the Australian Asthma Handbook for more tips or thoughts to consider. We've just added a couple of slides regarding asthma and COVID. Refer to the Australian Asthma Handbook for reference under COVID-19. But check everyone with asthma has a current written asthma action plan. And as I've said before, telehealth is definitely one of the best ways to review a written asthma action plan in these current times. If performing spirometry, follow the latest TSA and Z recommendations. Now, at the moment in both New South Wales and Victoria, spirometry shouldn't be being performed. I've written new guidelines in the last couple of months and updated them with help from the TSA and Z, which is the Thoracic Society of Australia and New Zealand. They put out recommendations late last year regarding spirometry, but if there is any community transmission of COVID, spirometry shouldn't be performed. So I would hope that in all clinic settings, no spirometry is being performed at the moment. If you did have a patient who you were relying on a diagnosis of asthma or something more sinister, we would always refer patients to our hospitals, to respiratory function labs. They are still performing spirometry at the moment, but when we get back into performing spirometry, things that we need to look out for, of course, our infection prevention and control guidelines, our 5 moments of hand hygiene that we're always performing anyway. But if you wanted to look up more of our spirometry infection control guidelines, pop onto the NAC website, look up COVID-19, and there's a link there to our recommendations. But as I say, not something that you need to be worrying about at the moment, because I think community transmission will be occurring for quite a while yet. Other things to consider though with asthma and COVID is, as I said before, a lot of symptoms are overlapping between asthma, allergic rhinitis and COVID. If anyone feels that their symptoms are exacerbated or just a little bit different to the usual symptoms, please advise everyone to go and get tested. Advise everyone to continue with their current asthma medications, including their preventers or their inhaled corticosteroids. It's so important. Only use oral steroids for severe flare-ups as indicated. Avoid using a nebulizer. A well-fitting mask and spacer with a puffer is preferred. That goes without saying anyway in treating asthma these days. Very rarely does a nebulizer need to be used. Nebulizer should only be used in life-threatening situations. So a well-fitting mask and spacer is always preferred. Advise patients not to share any medications or spacers, even between family members. And just remember that particularly, cleaning down any spacers, medications that you may be using if a patient comes into your clinic, disinfecting, all those bits and pieces that I'm sure you're all doing in the clinical setting now with COVID around us. So we're almost at the end now, guys. These are just a list of our resources: the Australian Asthma Handbook, as I've mentioned on numerous occasions, and the National Asthma Council website. You can get action plans, medication charts, the rhinitis medication chart that I showed before, those first aid charts, and many papers on thunderstorm asthma, allergic rhinitis management, intranasal spray techniques. We've also got the how-to device videos, and as I've just said, the spirometry infection control recommendations. Asthma Australia is also an amazing website. We work in conjunction with Asthma Australia. At the NAC, we are the educators of health professionals. Asthma Australia are more educators of the consumers, the patients, but we work very closely together. So 1800 Asthma is that coach program. And then finally is the Askia website, where you can find those treatment plans we went through earlier at www.allergy.org.au. This is just our acknowledgement page of the few of us that have put this webinar together. And finally, this is our page where we thank you so much for attending. This is a little QR code that we've added into the end of our webinar presentations. If you happen to have your phones handy, you can just grab them now and scan the QR code here. We find that it's a quick way to complete our evaluation. Guys, I'd really love you to complete the evaluation either now through the QR code, or Caroline's going to send you the link in an email. But our funding and our program depends on these evaluations. It's so important that you please be honest with us and tell us what you think of the webinars, or when we can get back to face-to-face workshops. It's the only way that we can improve our education to you. Tell us what you would like more of. Tell us what you would like less of. It just allows us to tailor the sessions to your needs. So I'll leave that screen up with the QR code in case anyone would like to complete that evaluation now. It doesn't take very long at all, only 5 minutes.
Thanks so much, Narelle. That was a really comprehensive, informative update.
Thanks, Caroline.
Okay, so many of you will be familiar with Murray Health Pathways, but for those who haven't yet logged on and had a look, Health Pathways is a free web-based portal available for use by clinicians at the point of care to access evidence-based, locally accessible patient pathways. More than 650 have been localised for the Murray PHN region, and with input from more than 100 health professionals. So the information provided in today's webinar is for information purposes only and does not take into account individual circumstances. Practitioners will need to make their own professional judgment on a case-by-case basis. For upcoming webinars, please check the Murray PHN website, and if you haven't already, you may like to subscribe to our events update. So thank you once again, Narelle, for your presentation today, and thank you all for attending this morning, and enjoy the rest of your day.
Thanks, Caroline. Bye, everyone.
Bye.